next speaker is Dr. Christopher Curie, talking about medication-based treatments for behavioral concerns, a child, adolescent, and adult psychiatrist at the Lurie Center for Autism at Mass General.
Can you all hear me now? Okay, I think we got it. All right, terrific. Nice to meet you all. My name is Chris Curie. Let me just get my slides all up here, and then we'll be good to go. All right, terrific. Hopefully you are seeing what I'm seeing over on your side now, which is the first slide of the presentation today. So I'm a child, adolescent, and adult psychiatrist. I see kids, teens, and adults with duplication 15q and other neurodevelopmental disorders at the clinic I work at, which is the Lurie Center for Autism. We're an outpatient clinic for Mass General Hospital for Children, and we're located in Lexington, Massachusetts. I want to thank the organizers for inviting me today to talk to you a little bit about our work with families who have a loved one with Dup 15q. And I'm going to talk about some of the more common behavioral concerns for which we might work with a child or a teen or adult and their families. We'll talk a little bit about medication-based treatments for that and non-medication-based treatments. Dr. Reynolds did a wonderful job of describing a lot of the non-medication-based treatments. So hopefully you hear a lot of similarities, and that's good, right? That means that we're thinking similarly, which is terrific. And I will also make sure these slides are available to you all afterwards, so you can reference them if you'd like to, and we'll leave time for questions. So these are disclosures. I'm not going to talk about any treatments today that have any connection with any of my disclosures. Similarly, I'm not promoting or selling any commercial related items today. We're going to talk about medications for different indications and behavioral concerns. So some of these have FDA indications for the treatment of issues like irritability, but some do not. Okay, we're going to talk about these three major areas of concern because they represent some of the more common chief complaints of families with a loved one with Dup 15q. And some of the areas where there's been the most research identifying these as being behavioral concerns. So we're going to go case by case. We're going to talk about cases, and then we're going to talk a little bit about what's known about that problem in Dup 15q based on research, and then we're going to talk about treatment ideas. So Alex, well, the cases I'm talking about are kind of amalgams of different kids and adults that I've worked with before, so to protect confidentiality for those kids and adults. Alex is a 9-year-old with interstitial Dup 15q. He's had somewhat of a delay in his motor milestones, first walked around 19 months, but had first words by 12 months and progressed nicely in his motor milestones and language to the point that he's speaking in full sentences, but has really rushed speech and challenges with articulation. Alex really wants to make friends, but struggles a lot with intelligibility in communication, and that gets in the way for him socially. The parents' chief concern was that of hyperactivity and easy distractibility. Some of the things they noticed were excessive talking. Alex would interrupt constantly, kind of on a whole different topic. He would constantly be in movement. Sitting was hard for Alex, constantly climbing, and could accidentally get some injuries from climbing in places where it was not safe for him to do that. Really required total supervision at all times for that reason. He got really upset with anything that asked him to wait. Unstructured time was really hard for him, and he would get into everything, kind of like bull in a china shop around constantly. It was born out of curiosity, but would end up taking things apart, breaking things inadvertently, although that was not his intention. What brought the family into treatment was this concern of his slow progress in speech therapy, with the speech therapist feeling like it was hard to work for more than 5 to 10 minutes with Alex before taking movement breaks, and that was slowing his progress in speech therapy. So what's known about the issue of hyperactivity in Dup 15q? So there have been a number of case series that have described this as a problem. One from 91, one from 2010, where hyperactivity was identified as a clinically significant concern. There was a more formal assessment done by a researcher, DeStefano, and her group in 2020 that did an assessment tool called the ABC, which has a certain aspect of it that measures hyperactivity. And in the subjects with Dup15q that she did this assessment tool with, there were high rates of hyperactivity that were identified among that patient population. It amounted to about 19 individuals with isodecentric Dup15q, and then 9 subjects with interstitial. But you can see in the dotted line here in this image, that represents sort of the mean score of hyperactivity in kids who have a developmental disability. And you can see there were many subjects in DiStefano's trial where they were scoring much higher than that. So it seems to be that there's some research that this is a real challenge. Let's talk about non-medication-based treatments first of all. I really like how Dr. Reynolds emphasized the importance of sleep, and I think that was really well stated, that if we're not getting good sleep, it's hard for our brains to be learning. It's hard for us to be making progress. The frontal lobe parts of our brains that are responsible for inhibiting impulses are perhaps not acting as well as they could be. So sleep is key, as is routine exercise. For some adults I've worked with Dup15q, hyperactivity may still be a problem for them. And I really believe in the importance of regular physical activity for kids, teens, and adults. If adults are attending a group home, for instance, that exercise be part of their routine. I think it's very important. Dr. Reynolds talked about some of these educational interventions, for instance, the behavioral approach. Applied behavioral analysis may be an example of this sort of a formalized aspect of this behavioral approach, using reward systems to incentivize kids, teens, and adults to hold their attention on something that may not be really motivating for them for a longer period. That can be a really helpful thing to integrate into education if it's not being done already. Frequent movement breaks, small class size, allow a lot of individualized attention. And for many kids and teens with Dup15q, there can be regression around that summertime out of school, and keeping some structure and routine through the summertime can be really key for addressing some of this hyperactivity, which can spike in the summertime with less structure. Occupational therapy has a lot to offer for kids who struggle with hyperactivity, because there can be a lot of sensory seeking behaviors, repetitive mouthing, chewing behaviors, rocking, different sort of repetitive sensory seeking behaviors that can be more intense in kids who struggle with hyperactivity. And occupational therapy, one of the many ways in which they can be helpful for kids with developmental disabilities, is that they can look at what are other ways in which that child or teen or adult can get that sensory input in a way that's safe, and ideally distracts less from on-task situations in education. Let's talk a little bit about medications as well. So guanfacine and clonidine was described by Dr. Reynolds as well. These medications, the way they work is kind of the opposite of how the fight or flight hormones work in our body. Adrenaline, colloquially called adrenaline, but the term for that, norepinephrine. Guanfacine and clonidine block some of the effects of norepinephrine. In this way, they're calming medications. They do kind of the opposite of the fight or flight response, and can be very helpful for hyperactivity. They're also, relatively speaking, a more mild place to start in terms of medications, making them very sensible for kids who are sensitive to medications or who are quite young, but who have very impactful challenges here. Side effects to watch for. Some of the most common ones include sedation, dizziness. Constipation can be a particularly concerning side effect with many of these medicines, and warrants sort of close observation whenever starting a new medicine. In kids who have contributing cardiac malformations of some kind, blood pressure and heart rate need to be watched pretty closely with these medicines, because they can have mild decreasing effects on blood pressure and heart rate. Stimulants, you've probably heard of, medicines like Ritalin, Focalin, Adderall, Concerta, Vyvanse. These medicines act to stimulate the release of dopamine in the frontal parts of the brain. That's thought to have an effect that's inhibitory on impulses, hyperactivity, making it easier to sustain attention and focus. These medications carry some particular concerns in kids, teens, and adults with Dup15q. If they're taken too late, they can cause insomnia, or some kids can be slow metabolizers of medicine. So watching for insomnia is important. They almost universally decrease appetite, which should be watched for. And some kids can get more irritable or more anxious taking this medication. So particularly in younger kids, starting at low dosages, short-acting versions of the medications, being in close contact with any prescribing clinician is very important, although these medicines can be really effective. Atomoxetine, the other name for that is Strattera. This has got kind of a novel mechanism of action. It increases norepinephrine in specific parts of the brain that are thought to have downstream effects on dopamine. Essentially, what makes this medicine unique is that it's long-acting. So individuals take it in the morning and it's, in theory, working all day, while the stimulant just works for very specific times of the day, and you want it to wear off by night in order for kids to sleep. So this medicine too can sometimes cause irritability in kids. Decreased appetite or nausea is not uncommon, as well as fatigue can be seen. These are some sort of things that might be rational steps to take from a medicine standpoint. All right, let's talk about the next case here, which is Jennifer. Jennifer, 16, she has isodencentric duplication 15q and also reflux, gastroesophageal reflux, or severe heartburn. Parents' main concern for Jennifer has to do with aggression towards them, towards parents, towards siblings. As part of Jennifer's developmental disability, she has particularly profound need for sameness. She sort of has a more autism spectrum disorder kind of behavioral profile, which is to say that small little changes in the routine are very hard for Jennifer to deal with. It's kind of always been that way for Jennifer, but as she's gotten older into the teenage years, it's now getting a lot more intense. So things like needing for the soap to be blue, and if it's purple, huge meltdown. We always take a left at this intersection when we drive to school, and if we take a right, huge meltdown. And the family is starting to increasingly feel like every little thing in their lives needs to be exactly the same, or Jennifer can get upset. Sometimes they don't even know what the trigger or the precipitant was that led to the profound meltdown. But limit setting becomes very hard for Jennifer. Transitioning away from it for activity is very hard for her. And because of that reason, community trips are increasingly unsafe to take with Jennifer. And the family feel like that's limiting her ability to have new experiences, go to new places, take that trip to Disney World. And it's also limiting her ability to have inclusion experiences at her school. So she has less opportunity for taking music with her classmates or art because of the concern for aggression. We'll talk about one sort of term for this that is used in the research world when studying this particular problem in kids with developmental delay is irritability, the way I explain this to families is sort of a quick emotional reaction, very poor frustration tolerance. And this is different than in kids who have it at only occasional times. For a lot of kids, they've struggled with some of these challenges their whole life, or going back to early development. So what is known about the problem of irritability in DUP15Q? So it was frequently described in some early descriptions of DUP15Q going all the way back to the 70s. There was a case series that described it, aggression and self-injury as a challenge. And a newer study in 2021 that was released not long ago, where they found a very substantial number of children in their trial had clinically significant aggression or self-injury, and that the intensity of those things correlated with the severity of GI concerns, things like constipation or reflux. So what do we think about as being treatment for irritability? I think Dr. Reynolds kind of talked a little bit about this, but aggression can sometimes have a communicative aspect in kids who've got limited ways to express themselves. And so giving kids, teens, and adults with DUP15Q that have limited ways to express themselves other strategies can really help with aggression. Being able to ask to take a break, having sort of a strategy to be able to do that can be just so useful in terms of managing frustration tolerance. So we want to make sure that kids get high quality speech therapy for kids with DUP15Q where that's a challenge. Assistive augmentative communication, AAC evaluations. I work with many adults who are in their 30s or 40s that didn't get a lot of that, AAC evaluations when they were younger. So ensuring everybody has an opportunity at good speech therapy is key. Behavioral therapies, Dr. Reynolds talked a lot about ABA. I'm not going to get too much more into that, but ABA is key for knowing the antecedents behind a behavior and the consequences. That can help clinicians identify, could this actually be depression? Is this really anxiety rather than frustration tolerance? Looking at sort of a functional behavioral analysis and FBA of aggressive behaviors can help sort of tease these issues out. And it allows you to track response to treatment if you start a medicine or start a new behavioral approach. So you have a sense of what's getting better. And as a clinician, I try to really think about medical contributing factors that might be causing the irritability in kids or adults who can't explain themselves or let me know very clearly how they're feeling. Epilepsy, headaches, dental pain, pain with menstruation, dysmenorrhea, all these things are common causes for irritability in kids who can't express themselves as much. GI concerns, constipation, and reflux is a particularly common one. And there was a trial that actually found reductions in aggression and self-injury when these issues were treated, which makes sense. So what is thought about in terms of medications for the treatment of irritability if it gets to that level where medicines are needed? I mentioned guanfacine and clonidine. I'll mention here propranolol as well, because all these medicines similarly work in a way of sort of blocking the effects of the stress hormones, the colloquially adrenaline, the fight or flight hormones. And they can all be calming and help with irritability and can be a safer place to start. Many anti-seizure medications, which kids or adults with DUP15Q need to be taking, maybe taking it anyway for epilepsy, can also really be helpful for irritability. Here are some medications in particular that I've had success with in terms of seeing it help with easy frustration or aggression or self-injury. These are some examples of the names of medicines. And if they are also good choices from a seizure standpoint, that might allow for less medications in total, which is always good. Benzodiazepines, which you may have heard of, lorazepam, which is Ativan, diazepam, which is Valium, clonazepam, which is Klonopin. These medicines have, they act on GABA, which is sort of a dampening neurotransmitter in the brain that decreases reactivity of the neurons. These can be very effective for treating agitation and aggression. However, the body can develop a tolerance to them easily, making them sometimes not the best long-term plans. And antipsychotic medications should be considered really in the most severe treatment refractory cases where problems with irritability are just the most impairing for individuals. These medicines block the effects of dopamine in the brain and can be really effective for reducing aggression and self-injury when it's severe. Special concerns to think about with this medicine include oversedation, constipation, and obesity. And more rarely, you can see tremors, muscle spasms, and a very rare condition called tardive dyskinesia, a sort of writhing movement of the muscles, which if ignored can be permanent. So kids taking these medicines or adults taking these medicines need to be monitored pretty closely by their prescribing clinician. All right, the last case we'll talk about is Anna, and then we'll take some questions. Anna is a 26-year-old woman of isodocentric chromosome 15. She has epilepsy. She was actually able to come off of her epilepsy medications, but when they did, she now has a new problem with middle of the evening wakening and wandering. There have been a couple studies that have found challenges of sleep are common in people with DUP15Q, and that mid-cycle awakening represents some of the most common problems. Dr. Reynolds talked a little bit about some of the sleep challenges. There's a lot of things that are common in DUP15Q that can make sleep more of a challenge, whether it's problems with toilet training, which can be compounded by constipation. Seizures at night are always a possibility of something that could wake individuals up. And then for some kids with DUP15Q, just having their body be calm enough to be able to lie down for the 10 to 15 minutes to sleep can be hard. And separation agitation or anxiety is not uncommon as well. Strategies that can help with separation agitation that are good places to start before medications include bedtime fading. This is sort of moving back the bedtime to later times, so kids are more tired when they go to sleep. And then when you got a consistent bedtime that's successful, inching that bedtime a little bit earlier to see if you can get back to a reasonable hour. Camping out, this is buying the cot and sleeping next to the child or adult and kind of gradually moving your cot out of the room little by little. Or the excuse me drill for individuals that need to co-sleep with their loved one of DUP15Q because of separation challenges, leaving for just 5 seconds and then coming back with lots of praise. You did it, way to go. And then next time you leave for 10 seconds, next time you leave for 15 seconds, and kind of extending that little by little with a big way to go at the end of it to increase kids' tolerance for being alone in their bed are some behavioral approaches. And of course, it's important to maintain good sleep hygiene, consistent routine, bedtime, and a quiet, cool, dark sleep environment. Here are some medications that can be effective as well for problems with sleep. Melatonin is always a reasonable place to start because in multiple trials in kids who have sort of a behavioral profile of autism have found it to be quite safe in short-term usage in these trials. Clonidine is a short-acting medication, but also can be very effective for sleep. Trazodone and mirtazapine are more longer-acting. These are antidepressants, and so they can also be helpful for anxiety. They have antihistamine effects that make them really effective sleep medicines, though mirtazapine can cause a lot of weight gain. Diphenhydramine and hydroxyzine, this is Benadryl, is similar to the active ingredient that's in things like NyQuil and can be helpful. Diphenhydramine and benzodiazepine should be used with caution in kids with DUP15Q because some kids can have a paradoxical response where they're more awake. Also, benzodiazepines should be used in caution in kids who've got sleep apnea or adults with sleep apnea, as it can be dangerous. And in very severe cases, really should be only considered in just the most severe of cases after behavior intervention has been tried. Quetiapine is an antipsychotic medication that is very sedating and I've seen it be successful in some of the most severe of cases, although weight gain is a major concern. All right, so in summary, I'll just finish by saying in the behavioral assessment of duplication 15q, clinicians should assess for challenges in areas of hyperactivity, irritability, and sleep as being some of the most common challenges. Effective treatment plans should take into account co-occurring medical conditions and comorbidities, which may be making things worse. An effective treatment plan for behavioral concerns is not just medications. It should include occupational therapy, behavioral therapy, communication strategies, all working together to develop a good treatment plan. And that future steps in this area is hopefully to understand more other psychological concerns and whether they're more common in duplication 15q. For instance, major depression, sort of the syndromic condition of severe sustained depression, or anxiety disorders. So why don't we finish up there? I've got some citations here that you all can take a look at if down the line, but I'll stop here for questions.
Thank you, Dr. Carey. I think even though this is a little bit more about DUP15Q, there's a lot of things that really apply across the other disorders that are in this room as well with 8P and Ring 14. So we really appreciate that. We have a few questions for you. So what would you recommend for an 18-year-old with major aggression, nonverbal, relatively low functioning, currently taking Thorazine and has taken Risperidone?
Right. So already it's gotten to the point that they are considering medications for this individual. In my evaluation, I'm making sure, so 18, in most states, they may still be in a school or school-based program, ensuring that that school-based program has good behavioral approaches and that there are, if it's a day school, ensuring that there may be behavioral approaches that are taken at home. It could be that those behavioral approaches failed because any sort of limit setting at all produces more aggression. That's not an uncommon story, but I'm making sure that that's something that's been considered and that we've also ruled out co-occurring medical conditions as being a reason why the medications have not worked until now. If medicines have not been really helpful, I'm thinking in my mind, have I missed constipation? Have I missed dental pain? Have I missed poorly controlled epilepsy? So risperidone is one of the most effective medications. Risperdal, it's antipsychotic medication. So if that's not been something that's helpful, I'm kind of wondering in my mind, did it not work or did it cause side effects? And so it was stopped for that reason. And the most common side effect with Risperdal is weight gain. So there are other medications such as ziprasidone, which is Geodon, lorazepam, which is Latuda, which carry less risk for weight gain, which might be a reasonable option to go with. Thorazine is a very sedating antipsychotic medication that's a little bit older. That medication carries a higher risk for tardive dyskinesia, which I talked about. Although in very severe cases, it can be something that's considered. There's a medicine similar to Thorazine called haloperidol, which is also considered in very severe cases. But we're just talking antipsychotics, other augmenting agents that may be considered. Thorazine carries a lot of risk for long-term effects. Maybe one of those anti-seizure medications that carries less weight gain risk, like topiramate, could be added instead of Thorazine, or Depakote. That may be more effective or as effective than Thorazine, but carry less of the risk for tardive dyskinesia in the long term. That's starting on the deep end, I think, of the.
Yeah, no, that was actually extremely informative. Can you talk about the interactions of medication for epilepsy and then the medications that you mentioned?
Yes, absolutely. It's so when it comes to drug-drug interactions between them, the most common concern is that of oversedation due to drug-drug interactions. There are a number of seizure medications, such as carbamazepine, which is Tegretol, that can have a lot of drug-drug interactions in general. So it's very important that anyone who's prescribing medications for a child or adult with Dup15q or other neurodevelopmental disorders know about all the medicines that person is taking to look for drug-drug interactions. You know, and then also to look at constipation can be caused by some anti-seizure medications. And now if you're adding a behavioral medicine on top, you may really be exacerbating that issue of constipation. And so that's why, as much as possible, I try to collaborate with neurologists to, can we use anti-seizure medications that are effective for controlling seizures that also help with behaviors? Medications like Depakote, which is valproic acid, carbamazepine, which is Tegretol, some of the other ones I listed there, those can be two birds with one stone and reduce the risk for polypharmacy.
A really important point that a good clinician or your doctor would consult with the other experts that are needed. In this case, it would be like an epileptologist or neurologist as well.
Yeah, well said.
If my child only struggles with sleep during her period, which I believe you mean when she's menstruating, should we try to medicate?
That's a good question. So I've seen some families pursue birth control to help with either pain with menstruation or sort of behavioral changes that may occur in the 5 to 7 days prior to the onset of menses. And that's a discussion to be had with a gynecologist to look at the risks and benefits of considering a birth control medication. But I can tick off 5 patients I've worked with where it made a big difference in behavior and was a much better choice than reaching for an antipsychotic medication. So it definitely is something worth considering.
In addition to psychiatry, are there other medical specialties that would help coordinate or diagnose these issues that you actually described during your presentation?
Yeah, developmental pediatricians have a lot of expertise in this area, as do many pediatric neurologists. Psychologists who do neuropsychological evaluations are also able to make diagnoses of mental health conditions, in addition to like a autism spectrum disorder diagnosis. And they can be particularly savvy with piecing out what might be challenges related to autism behavioral profile versus a separate mental health condition like an anxiety disorder.
Great. And then you have a lot of questions, so I might have to unfortunately get back on some of these things.
I'm okay with you sending them to me and responding to some of them that way, if you want to do it that way.
Okay, and they're good questions. So that would be great. We're just trying to stick to the schedule and we're a little behind, but we'll send them over to Dr. Carey. Really appreciate you getting back to us, and then we'll share that with the community here.